Thank you very much. Dear chairpersons, dear colleagues, dear friends, it's a pleasure for me to talk today about rule-out algorithms, as we have heard some of them already. I want to open my presentation with reading again the title of the presentation with emphasis on direct comparison of the ESC01 algorithm and the high-stakes pathway. Chest pain has been a problem since ancient times for over 1,000 years. It's known that this might be a symptom of potential danger and death, maybe. But this gentleman here is Mr. Willem Einthoven. He introduced the ECG 100 years ago, and he won the Nobel Prize for this 99 years ago. And this has been the first major improvement in the early diagnostics of myocardial infarction. And with the introduction of biomarkers 50 years ago, and especially troponin about 20 years ago, major importance has been, and the concentration on early rule out of myocardial infarction, and the diagnosis was based on this finding. Many different rapid rule-out pathways were introduced in the last decade, and I just want to give you a quick overview about all the different possibilities that there are. There have been approaches using only one troponin, using troponin together with clinical risk scores, using troponin and other biomarkers such as, for example, copeptin, or using two measurements of troponin at different time points at 0 and 3 hours, 0 and 2 hours, and 0 and 1 hour. Among all these different pathways available, the two most promising and currently most validated and recommended pathways are the ESC01 algorithm and the high-stakes pathway. We have heard them before, but I want to repeat the most important features of these pathways. Both of them have been validated for the high sensitivity Abbott architect assay. First, the ESC01 algorithm uses a 0-hour and a 1-hour troponin and rules out patients if the first troponin is very low or if the difference between the two troponin measurements is below 2 for this assay, and rules in patients if the first troponin is very high or the difference is over 6 nanogram per liter. If patients do not meet these criteria, then they are triaged towards an observed zone. This does not exist for the high-stakes pathway. It also takes a troponin at the 0-hour time point, and if it's very low, patients are ruled out. And it takes the difference between the two 0 and 3-hour troponin measurements. And if it's below 3, patients are ruled out. Or if any of the two troponin measurements is above the sex-specific 99th percentile, patients are ruled in, no observed zone. Our aim was to directly compare these two pathways. So we performed an international multi-center study recruiting patients prospectively who presented to the emergency department with chest pain or chest discomfort, symptoms suggesting acute myocardial infarction. And we then finally adjudicated all these patients based on all clinical information, imaging data, and serial measurements of troponin. In this case, we took troponin I. And according to the universal definition of myocardial infarction from 2018, adjudication was performed. For our specific analysis, we excluded all patients with STEMI, all patients with unclear diagnosis and troponin I was elevated, and dialysis. And importantly, we excluded all patients in which one of the two algorithms was not applicable. Our endpoints were type 1 and type 2 in STEMI, and to allow for an fair comparison between the two algorithms, we performed a sensitivity analysis for type 1 and STEMI only, because the high stakes pathway was primarily designed for the detection of type 1 and STEMI. This was our patient cohort that we used. More than 5,000 patients were available for our analysis. 1/3 was female, 1/3 had known coronary artery disease history, and 1/4 were early presenters. These cannot be ruled out by the first troponin, by the 0-hour troponin. They require a second troponin. When we come to the results, I provide a flowchart of the two pathways, and I will go through them from 0-hour, 1-hour, and overall. So the ESC01 algorithm ruled out with the first troponin 40%, 43%, and missed 2 patients with myocardial infarction. And with the difference criterion, 1 additional patient was missed, resulting in an overall rule out of 60% of all patients. So totally 3 NSTEMIs were missed, 60% were ruled out, and the positive predictive value was 75%. In contrast to that, the high stakes algorithm ruled out 45% with the first troponin, and overall 70% of all patients. With the first troponin, 4 NSTEMIs were missed, and with the second troponin, with the delta criterion of 3, additionally 7 patients were missed, resulting in 11 missed NSTEMIs in total. The positive predictive value was 66% for this pathway. When we look at the direct comparison of the two pathways, and we check the safety measures, sensitivity and NPV, we find a small but significant difference of 0.7 for sensitivity. For specificity, we find a difference of 5.3 in favor of the ESC01 algorithm. But when we check the proportion of ruled out patients, we find that 10% patients were more ruled out with the high stakes pathway. We performed a subgroup analysis for age, sex, and history of coronary artery disease. And on this slide, you can see in blue represented the ESC pathway, in red is the high stakes pathway, and the vertical lines, they represent the overall performance of the two pathways. On the left side, you see the proportion of rule out, and it's very clear that for patients older than 70, the ESC pathway can only rule out 1/3 of the patients. Similar results we obtained for history of CAD positive. When we look at the sensitivity, we see that both pathways perform very well for all investigated subgroups. Now I come to the sensitivity analysis for type 1 and STEMI only. As you can see, the ESC pathway missed not a single patient, so all the 3 patients that were missed were type 2 MIs, and the high stakes pathway missed 5 patients. The difference of 5 and the difference in sensitivity remain significant. Limitations, of course, we have some limitations. Some are in the pathways in general, where we see that we can only apply them in patients presenting to the emergency department with chest pain, so not for the ICU or different clinical settings such as post-operative setting. And we cannot apply them in patients without symptoms when we, for example, measure troponin as a routine control and it is elevated. We excluded all patients when the pathway was not applicable, so efficacy might be overestimated. And of course, the character of the study is observational. That means that safety is probably underestimated and efficacy is overestimated, as clinical data and all this information is part of the diagnosis process in reality. I come to the conclusions, and the first and I think most important conclusion of them all is that both pathways are very safe and provide very high sensitivity of over 99%. The high stakes pathway identifies a higher number of patients at high risk. This is the advantage of the high stakes pathway. On the other hand, in contrast to that, the ESC algorithm provides even higher safety, especially the case that it does not miss any type 1 NSTEMI is showing that. And both pathways are better for the application on type 1 NSTEMI. Thank you all for your attention, and thank you very much.
Yeah, thank you, Jonas. Very nice analysis, very nice presentation. There's a question, yeah, in the rear.
Hello. Yeah, excellent presentation. Thank you very much. Just a quick comment. The ESC pathway was developed in this data set, so it is probably worth mentioning a limitation is one was playing at home, the other pathway was playing away, so we cannot really compare them.
Yes, probably some part is right, but these are not the same patients in which the pathway was required, so the patients are different from the same data set, but not exactly the same patients that we used for this analysis.
So the two people are sitting up there, the one who is responsible for the ESC01 algorithm in the ESC NSTS guidelines, and the other one who developed the high stakes pathway. So probably both of them will have to give a comment.
A joint comment.
We sing a duet usually.
Yeah, okay, so very nice presentation. I have a couple of thoughts. First of all, the high stakes pathway is a rule-out pathway only, with no attempt to rule in. It's actually risk stratification, not diagnosis. And it makes a decision in everyone. So nobody's in the observed zone. And as we all know, all the patients that end up in the observed zone are the difficult ones. And so if you have a pathway which dichotomizes into two groups, then it's never going to be directly comparable one that takes an approach of three groups. Second point to consider is that the high stakes pathway was developed using sex-specific diagnostic criteria and for a diagnosis of type 1 myocardial infarction specifically, or for B and C. Because patients who have type 2 myocardial infarction don't go into these pathways. They've come in with pneumonia or atrial fibrillation, and they get managed for that condition. And so that definitely influences your apparent differences in sensitivity. But I think the conclusion is that really that both these pathways perform very well in a controlled, consented study. And the true test is to implement them into practice and demonstrate the impact on patient care.
Just one additional question. So what kind of patients were this? Were this patients from a PACE or were this additional patients added? So what kind of patients have been included in this analysis?
These are patients from a PACE study. Yeah.
Okay. I think for the sake of time, also regarding the cocktail reception, we have to move on.